Hi, my name is Justine. I'm really excited to introduce Dr. Ann Thomas. Ann is a pediatrician and a public health physician. She has close to 20 years of experience tracking and responding to infectious diseases at the Oregon Public Health Division. Anne is the principal investigator for the CDC's Viral Hepatitis Prevention Grant, and she supports many collaborative projects around the state of Oregon, including the Oregon Hope Study and Prime Plus. I consider myself really lucky to get to work with Anne on these projects, and I'm excited that she's sharing with you all here today. Anne is not only a very committed bicyclist, she also recently completed a certificate program in science writing at Johns Hopkins University and writes about health and environmental issues. Thank you, Anne.
Good morning. I'm Dr. Ann Thomas. I'm a public health physician in the Acute and Communicable Disease Prevention Program, overseeing hepatitis surveillance. And I'll start with my overview here. Today I'll be showing you some surveillance data about acute hepatitis A, B, and C, as well as chronic B and C. We'll look at some testing trends for chronic hepatitis B and C, take a more geographic view of the burden of disease related to injection drug use in Oregon. I also have some data on liver cancer and hep C related deaths in Oregon. Our immunization program has thoughtfully provided us with some data on hepatitis B vaccination, and I've worked with Office of Health Research to get data from the all-payer, all-claim system and allow us to look at some trends in hepatitis C treatment. And lastly, we'll talk about some of the prospects for hepatitis elimination in Oregon. So these are the cases of acute hepatitis by year in Oregon for the last 10 years. The light blue is hepatitis A, the bright green is hepatitis B, and the dark blue is hepatitis C. So we've kind of been averaging, for hepatitis A, we actually had pretty low levels at the beginning of the decade, and it's kind of creeped up again in the last few years. Some of that is probably related to a national trend. There have been some really huge outbreaks of hepatitis A in the homeless and among people who inject throughout the United States. And we have not had any big outbreaks, but we've had some spillover into our state. Otherwise, the trends for hepatitis B and C have been sort of hanging around the same, around sort of 20 to 30 cases a year. Although typically for hepatitis C, we think that since most people, when they first get hepatitis C, are asymptomatic, there's clearly much underreporting. So, in 2020, we're showing, 33 cases of hepatitis C. There were probably several hundred that were unrecognized. If we look at the age group of cases of acute hepatitis, and here the cases of A are in the dark purple, the light blue is hepatitis B, and then the bright blue is hepatitis C. The first thing that stands out is that the 20 to 29-year-old age group, gosh, that's when a lot of people get hepatitis C. And I think for those people that get acute hepatitis C, most of them acquire it through injection drug use, and this is the age when you first start seeing it, although it looks like we did have a few teenagers. After that, there are fewer cases. We think that most of the people that are ultimately diagnosed with hepatitis C, who often tend to be older, probably acquired it many decades ago. And here this really shows that, like, the age for acute hepatitis C. The other thing that's interesting is all of the other two, hepatitis A and B, are pretty low in the first 2 decades of life and then go up. And that's largely due to the success of our routine infant immunization programs. Over close to 90% of Oregon 2-year-olds have been vaccinated against hepatitis A and B. So it's rare to see cases in kids. And in fact, although we did have a few cases in kids and teens in the last few years in Oregon, most of those were unvaccinated, and a couple of them were actually associated with Guatemalan immigrants who were they actually acquired it in a border detention station and then became symptomatic here in Oregon. But typically for hepatitis A and B, the peaks tend to be in their 30s and 40s because people younger than that were immunized as children. For gender, we see that both hepatitis A and B tend to affect males more often than females. It's about even for hepatitis C, which is sort of interesting because we know when we look at chronic cases, again, which is diagnosed among older people, we tend to see it more commonly among men. And that's kind of, again, that's kind of a reminder, those people who all acquired it, maybe 20, 30, even 40 years ago, and perhaps there were more people, acquiring it through the route of injection than, whereas these days, those numbers seem to be the acute hepatitis cases, particularly those people in their 20s, we tend to see an even breakdown between men and women. For the race and ethnicity on the right-hand column, I just showed a percentage of the different racial groups in Oregon, so you can kind of use that as a comparison as you look at the percentage of cases that occur for each of the types of acute hepatitis. So for instance, for hepatitis C, 3% of the cases occur in American Indians or Alaska Natives, even though they make up only 2% of the Oregon population. Among Asians, they make up 5% of the population, and so they aren't, disproportionately represented among our cases of acute hepatitis. But if you go to the next line for Blacks, you'll see that 5% of our hepatitis C cases occurred in Blacks, even though Blacks only make up 2% of the population. And then, although many times people lump Pacific Islanders together with Asians because the numbers of each of them are small in our state, I think it really stands out here that they do make up, 2% of the Hep A cases and 4% of the hepatitis B cases, even though they make up less than 1% of the Oregon population. And then lastly, if you kind of scroll your eyes down mentally to the bottom row in the Latinx population, their number of Hep A cases about the same as what you'd see in the population, and they actually seem to be at maybe slightly less risk for hepatitis B and C than the rest of the population here. Now, these are the risk factors for acute hepatitis A, and these are all recognized risk factors. What's unusual is that probably 5 years ago, we were seeing very few of these traditional risk factors, except for the foreign travel. Usually, typically, more than half our cases would be in someone who had traveled internationally or had never left the state, but their family member had traveled internationally, so they acquired it from the returning traveler. Whereas here we only see 15% associated with foreign travel. 10% of our cases did acquire it through contact with another person with hepatitis A. Most of these people had not traveled before, and these are all sort of more like household or friends or other contacts. We did see a small number occurring in persons who inject, men who have sex with men. But again, it's surprising because often we do see like MSM is often a more common risk factor. We also did have a few cases among homeless and people using, when I say street drugs, they're other illicit drugs that are not acquired through injection, which is not surprising because really the main way that hepatitis A is spread is its oral fecal transmission, like any other foodborne disease. So you're more likely to get it from sharing a cigarette or a glass with someone than you are from, sharing from really bloodborne injection. Just handing drug supplies back and forth is the risk factor rather than actually injecting. For hepatitis B, it's quite clear that injection drug use was the most common risk factor. Again, also some contact with hepatitis B, typically in a household setting, and some cases among men who have sex with men or people reporting multiple sex partners in the last 6 months. But not that many as we typically see. We usually think these days of hepatitis B as really an STD, and that hasn't been so common in the last 5 years. Although, again, there are a high number of people who didn't have a known risk factor, as you see in the gray. But the other ones, the other kind of big risk factors were healthcare associated, which meant that they had either a transfusion, an infusion, which is basically any kind of IV infusion, dialysis or surgery. And then our other risk factors, we kind of lump other sort of blood exposures together, illicit drugs, needle sticks, tattoos, piercings, other blood exposures. For hepatitis C, injection drug use is far and away the most common route of transmission, followed by kind of what we saw in hepatitis B, the healthcare exposures and some of the other risks that also would involve a blood exposure. And then less commonly having multiple sex partners or having a history of incarceration. So now let's switch to the chronic hepatitis B and C. This shows the number of cases of chronic hepatitis B reported in the last 10 years. You can see we sort of typically have been averaging 400 to 500 in the last few years, and we have had a decrease in the last few years. And for 2020, although the data are complete, I'm always concerned about whether there was as much testing and because there's less health-seeking behavior. But clearly, that downward trend is seen in 2018, 19, and I don't have an explanation for that. Kind of one of my goals for this year is to spend more time kind of looking at some of these cases a little more to see if we really are making a dent in the cases of chronic hepatitis B in Oregon. If you look at the age group and gender of the cases, again, there are very few young people. It's more common, it really sort of takes off in 30 to 39 year age group, and then kind of in the decades after that. And just as a reminder, like hepatitis C, many people are asymptomatic for years. So I think many of these people probably acquired it at birth, but weren't recognized at the time, and have been living with it silently. And this is kind of a more common age at which people would get screened. So that's kind of not surprising that that's when we would find this would be the age group for our patients. Here again, if we look at the race and ethnicity of the cases of chronic hepatitis B, what really sort of jumps out at you is the number of Asians. Despite being only 5% of the Oregon population, they make up 44% of our cases, and only 28% occur in whites. Again, the number is quite as big, but Pacific Islander, 3% of our cases, even though they make up less than 1% of the Oregon population. And Blacks are also overrepresented at 6%. And lastly, it looks like our Hispanic or Latinx population are less at risk for chronic hepatitis B. Although whenever you have, someone who seems to be at lower risk, I always wonder if maybe they're not being tested as much. And it's kind of on my to-do list of things to look at. For the risk factors, and you may have guessed this already when I showed you that the most common groups affected really are Asians and Pacific Islanders, that really our most common risk factor is birth outside the United States. That's over a third of our cases. After that, the most common risk factor is having multiple sexual partners or contact to the case. That's 16%. Those would typically be households. So probably many of those are people now like living with someone who's acquired it, who was born outside of the US. And then much smaller numbers for kind of the other risk factors we think about, other sex risk factors like having had an STD. And then you'll see some of the other risk factors like transfusion or working in healthcare, needle stick, but those are all fairly small. Now we'll look at cases of chronic hep C in Oregon over the last decade. And you'll see that there appears to have been kind of a dip in 2012 and 2013. And that was actually because CDC had changed their case definition to actually require having an RNA, so really requiring confirmatory testing before you consider them as a case. And then since then, they've relaxed their case definition. So in Oregon, if you have a positive antibody test, you'd be considered a case. And so really in the last few years, we've been seeing 5,000 to 6,000 cases a year. That's roughly 10 times the number of cases of chronic hepatitis B that we see in our state. And we have had a drop in the last 2 years. I think it bears some investigation. And I do have some data to kind of maybe help explain the drop in 2020 coming up. Here, if we look at the age and gender of cases of chronic hepatitis C in Oregon, you'll see that there's sort of two groups that are affected. I mean, historically, we've always seen it in sort of baby boomer populations, people who acquired their disease 30, 40 years ago. But again, after showing you that slide of how in the last 5 years, like kind of the biggest age group affected with acute or new cases of hepatitis C, you can see that we're also seeing a lot of cases in people in their 20s and 30s, which we really think is due to increasing injection drug use in Oregon. And then this is data that I'm thankful to Jeff Capisi in our HIV section. He often pulls out some Hep C data while he's doing his HIV annual reports. And so this top line, it shows from kind of August through July. The blue line on the top is the average number of cases reported per month in the state, and it always sort of hovers around 500, a little bit lower. And what's interesting, the purple line shows the number of cases identified starting in August of 2019, and maybe it was a little bit lower. And then surprise, in February and then in March, we had huge drops in the number of cases identified. It's clear that perhaps people are not seeking care, and because typically this would be done as part of like a routine exam. And in some cases it's done because people are having symptoms, but it's often done more likely just as part of a routine screening. And we saw that there was a really big drop, and it started to creep up in July. We haven't had a chance to pull the data by month for the rest of the year, but I mean, we know overall our numbers have been down in 2020. And this shows a more kind of breakdown, again, over time by much smaller age groups. And clearly what it shows is the lines on the top, the green, and then the yellow and black dots are the 50 to 59 and the 60 to 69-year-old age groups. And what you can see is that they were the people who were most likely to test positive and get reported to OHA. And that has slowly gone down over time in the last few years. Kind of the middle group, it's sort of the black and the light blue, and then the lime green lines are the people in their 20s, 30s, and 40s, and that stayed constant. The line on the bottom, that's the 70 plus, and they've always had sort of the lowest, rate of Hep C positivity, and that stayed about the same. But the good thing is that, so it is sort of interesting that, probably the testing went down, but it really has been kind of going down in that age group. And I'm wondering if we're starting to make a dent in the older age group of actually identifying all the people that have hepatitis C. Now, this is the all payer, all claims data from the Office of Health Analytics. They were able to look at people who've been, actually I should go back, the all payer, all claims data. The state of Oregon has made insurance claims reportable to OHA. And so this is true of whether you have private insurance, Medicaid, or Medicare. Obviously, you wouldn't be found in this, we wouldn't find any data on you if you were uninsured, because that wouldn't be reported to us. And also the federal payers, so armed forces and the VA don't report to this system. And in some cases, the numbers look very low for the number of Hep C tests performed in 2010, because that was when the system first started and the reporting wasn't good. And so we've kind of gradually over the last few years gotten to the point where we now have over 90% of Oregonians represented in this data set. But I find it very reassuring that the trends are definitely going up for hepatitis C. Unfortunately, with this data set, we can't tell who's positive. We only know who's getting tested. But one thing the analyst Marianne Evans, who works for the All Payer All Claims program, she did look to see if they had ever had a Hep C diagnosis in the previous 2 years, and only counted the tests. So we think these were people who were being newly tested, not someone who was having follow-up RNA tests done because they were being treated. This shows some of the characteristics. I think it's interesting that we, in the last 10 years, we have been better about screening people, because certainly we haven't had 80,000 people reported with acute hepatitis C in the 20 to 29-year-old age group. We only have very few. So it is good to know that people in their 20s and 30s are getting screened. And if you look at the payers, because we are able to break it down, you see that just over half of them had private insurance, but a third of them have Medicaid and Medicare. So those groups are getting screened as well. We also have some data on persons being screened for hepatitis B, and again, those numbers have gone up. And here in particular, those numbers have really stayed pretty high for the last few years. So even though the number of cases reported has gone down, this is a very rough way of gauging and saying, well, it looks like we're still doing a fair amount of testing for hepatitis B. Here, the age group, if you look at it, it's very striking that it's people in their 20s and 30s are getting screened. And I think the explanation for that, particularly when you see that 69% of the people screened are female, is that this is a routine prenatal screening test that's done. So I think that explains the high numbers in that younger age group, even though most people who are diagnosed tend to be in their older age group. And then next, I'll turn to some of the maps that Jeff Capizzi has made for me. It's really kind of taking a look at the geography of infectious diseases that are related to injection drug use. And this one shows the rate of persons living with HIV who reported injection drug use or have had sex with someone who injects drugs. And you can see that, some of the counties that really light up are, Multnomah County lights up, but many of the other ones are in very rural parts of our state. And so I think we always need to, as we design programs, to look outside the Tri-County area or outside of the Willamette Valley when we're thinking about designing programs and really finding our hard to reach populations. Again, I think it's very interesting that when we look at people with chronic hepatitis C, and here it's been limited to 13 to 29 years because those are the people that are most likely to have acquired it through injection drug use. Again, you kind of see some of these trends that, in fact, Multnomah County doesn't even have as high of a rate as Columbia County, or as you go down to the South Coast or look at Malheur and Baker counties. The really highest, the most affected areas of the state are not in our urban areas. And then lastly, Jeff has published work where he's looked at people who were hospitalized with typically bacterial infections, things like abscesses and bloodstream infections, heart infections, and bone infections. And again, we've seen the trends going up markedly in the last decade. And again, we see that this is a problem that occurs in every corner of our state. In previous years, we'd had the opportunity to get data from OSCAR, the Oregon State Cancer Registry, and cross-match it with our hepatitis B and hepatitis C surveillance databases, and found that really a very high proportion of the cases of liver cancer are related to hepatitis C. And this year I had a good excuse last year, but we haven't had the bandwidth to do as much analysis as we like, but I was able to get some data from the Cancer Registry that shows that, up until 2015, we did have a steady increase in the cases of liver cancer in our state. And then they've sort of plateaued and even gone down a little bit in 2018. And this is the most recent data they have, but I'm very anxious to see data from 2019 and 2020 to see if it's going down, because people have predicted that once you start treating for hepatitis C, you'll start seeing less liver cancer. And unfortunately, the deaths have maybe leveled off a little bit. I spoke to Atif Saman, gastroenterologist at OHSU, and he said that I think it's probably going to take a few more years before we start seeing declines in the cases of deaths from liver cancer. Many people who get to that stage often have a combination of cirrhosis as well as the liver cancer, and their livers will not recover even after they've been treated for the hepatitis C. But I think it is encouraging that we're starting to see some impact. Here's some of the characteristic of the cases of liver cancer in Oregon. This is in the most recent year. We have the rates. One thing is you can see that it's much higher in people 65 years of age and older. It's sort of that cumulative effect of the damage the virus has done to the liver. And here we have the rates. You can directly compare. You can see that African Americans had a rate of liver cancer more than twice that of whites in 2018. Both American Indians, Alaska Natives, and Asians and Pacific Islanders had a higher rate than whites, as did the Latinx community in Oregon. And then lastly, you see that it's more than twice as likely in men than women. This I'm taking as another positive sign. This is data from death certificates, and after peaking in 2014, we have had some decreases in the numbers of deaths from hepatitis C in Oregon. And unfortunately, we don't have the 2019-2020 data, but hopefully we can get that in the next year and see that, again, the numbers of people being treated is really starting to have an impact. And then I was able to get a little bit of data on hepatitis A immunizations in adults. We don't have data on the percentage of people covered by vaccination, although we know it tends to fall down once you get into your 30s and 40s. Not as many people have been vaccinated, but this shows some interesting trends, by year and by month, how many adults get vaccinated against hepatitis A each year. And it's kind of been pretty steadily around 3,000 doses a month for the last few years. And then in 2020, bam, just as we saw with, the diagnoses for hepatitis C, the number of people getting hepatitis A vaccines really dropped by last April and really have not recovered that much. This shows the same data for adult hepatitis B immunizations. And again, see that about 5,000 adults get vaccinated in Oregon every month against hepatitis B, and that really dropped in April and has come back up some, but clearly not enough. This is from the APAC data again, so that's the kind of the insurers reporting system. And again, the numbers for treatment of hepatitis C, some of this is the fact that not many people got treated because the treatment was difficult and not as effective in the early period shown on this graph. But it was also that, we didn't have complete coverage of everyone in the state, whereas now most people are covered by insurers that are represented in the APAC data set. And it's very encouraging to see the numbers going up in the last few years. This shows some of the characteristics of people initiating treatment for hepatitis C. It's interesting that even though a lot of people in their 20s and 30s are getting screened, they still aren't getting treated. So that's still something we need to work on. It is good to see that we do have a fair number of patients on Medicaid and Medicare being treated. And this is actually kind of going back to some slides that I showed you last year. We've been working with the Center for Disease Analysis on some modeling projects, and they were helping us do some calculations on how many people we would need to treat to eliminate Hep C in Oregon. And the WHO kind of developed this plan that if you have a combination of treatment, so that means that there are fewer people with hepatitis C walking around, so they're not spreading, and with harm reduction, which means that you're doing things like syringe exchange, so people are injecting more safely, and also trying to recruit them to help more people start, medication-assisted therapy. That will, reduce transmission. Could probably prevent 20% of new infections that way. And then there's a plan B where if you didn't do harm reduction, but you just started treating more patients, you could reduce the numbers of new infections, although you would have to be treating a lot harder and treating a lot more people if you aren't doing harm reduction. So of course, I think most of us would vote for plan A. And this is kind of a complicated slide, but stick with me here. This first row is showing, if we think standard of care, that if we treated, 4,500 patients in 2019, which is about what I showed you on that previous slide. And then based on national data, the Center for Disease Analysis predicted that maybe we might not have quite so many in the next few years, but that would kind of keep the number of new infections constant. However, if you go down to this next row that shows plan A, where you're doing harm reduction programs and treating fairly aggressively. So that would mean treating 4,500 in 2019, 3,200 in 2020, 3,200 again up through 2024. That then your new infections would go down 1,200 in 2020, 900 in 2021 through 2023. You could get down under 500 new cases a year in 20 to 24. So that would be great. And, we did manage to treat that many. So if we can keep these numbers up, that seems very feasible. Plan B is if you were just doing treatment and not harm reduction, you would have to be treating a lot. If you look at this bottom row, you would need to be treating 5,000 people a year, and your numbers would come down marginally. So I think what we want to be doing is, and you'll be hearing about this the rest of the day, is the combination of treatment and harm reduction. But, if you look at these numbers, I think we are kind of starting to hit those in Oregon. So I just want to end by saying, with kind of a few thoughts at the end here. The downside is we are still seeing some marked racial disparities, and we need to start catching up. That's really an area we need to focus on. And it's not only, in the Portland area, or the Willamette Valley, it's in all corners of the state. Clearly, this last year, it's kind of the understatement of the year when I say that the pandemic has kind of been a setback for us. Many of our plans on all levels have fallen by the wayside, and we haven't maybe done some of the things we wanted. But I think you're going to hear some encouraging things that have been achieved in the last year. And even though the pandemic has certainly hampered our screening efforts, I think we're getting to the point where we can start catching up again. And the good news is that at least the data through 2019, our capacity to treat is increasing. And with the dropping of many prior authorization requirements by the Oregon Health Plan, we still have opportunities to really ramp up treatment even more. And I think that if we can work on all of these things, the racial disparities and getting our treatment and screening back where it was prior to the pandemic, and continue to grow those efforts, because I think we're also poised to do a lot more harm reduction in many counties in the state. I think that our elimination goals are really in reach. Thank you very much.